Probably you heard this before, but I'm not sure. We performed a phase 2 study with 177 lutetium PSMA for salivary gland cancer. And I will show you the preliminary results. And we called it the LUPSA study trial. And I will show you the ACC cohort. And it was sponsored by the Dutch Cancer Society, the KWF, and the organization of JEF, the ACC Research Foundation. And thanks for the support. Now, this is known, of course, it's not needed to tell you. But we performed this study in adenoid cystic carcinoma in 10 patients, and we tried to offer it also in 5 salivary duct cancer patients. And of course, I will skip this. And that there are new treatment options needed, well, you all agreed. Well, and what was the case? In cancer, especially prostate cancer, it is known that there is an antigen. It is like it is on the surface of a prostate cancer cell, and it was called a couple of years ago prostate-specific membrane antigen. And they thought, well, it is present in prostate cancer, therefore the name, but in the meantime, we know that it is also present in salivary glands, normal salivary glands, but also in other tumors like sarcoma, certain sarcomas, brain tumors, etc. And in salivary glands, so not salivary gland cancers, but normal salivary glands, there's physiological expression of PSMA. And well, we performed first because we saw in 2016 in a patient which had a prostate cancer and an adenoid cystic carcinoma, so a double tumor, we saw in that patient that PSMA was not only present in his prostate cancer cells and metastasis, but also in his adenoid cystic carcinoma metastasis. And we differentiated with taking biopsies. So we did know what was the adenoid cystic carcinoma part and what was the prostate cancer part. And that was the reason that we started a prospective PSMA imaging study in salivary gland cancer. And we performed that study with gallium, 68 gallium. And well, I will try to explain it. So PSMA is present on the surface of a cancer cell. And when you are making a kind of antibody, which will go to the antigen, the PSMA, on the surface, and you put gallium on the end of it, you can see it like an FDG PET. You make a PET, and the metastasis or the primary tumor will come up. You can see it very easily. And when you give, lutetium, then you have on the end of PSMA a radioligand, which will kill the cancer cell. So the lutetium is for the treatment, and the gallium is for diagnostics. So before treating also prostate cancer patients, you perform first a study, or not a study, you gave those patients gallium PSMA to see if the tumor cells are positive. And if they are positive, then you know, hey, PSMA is on the surface of those cells, and then you can offer them lutetium, and that can kill the tumor cells. That's the way it is in prostate cancer. And so first we thought, well, we see those metastases. Let's perform first a PSMA imaging study in salivary gland cancer. And that was with gallium. I hope you can understand if I explain it this way. And we performed it in 25 patients, 15 adenoid cystic carcinoma patients and 10 salivary duct cancer patients. And what we observed is on the figure A, you need to believe me, I'm sorry for that, but this is the hip bone of a patient, so very low in the body. And this is not very special, it looks normal. I'm sorry for that, but the patient had pain. And then when we looked on the PSMA imaging, well, we could very easily see that this patient had metastasis in his bones, because all the yellow light are metastasis. And so we found that PSMA PET imaging has added diagnostic value compared to CT in selected patients. And here I show you other examples. I'm not sure if you could see my pointer. Can you see it? It's now red.
Yeah.
Yes? Okay, thanks. So this patient, these are the normal salivary glands. Then you see here lung metastasis, a lot. This is in another patient, lung metastasis. This is a brain metastasis in a salivary duct cancer patient. This is a patient which was treated with chemotherapy. And you can see another picture than in this patient, because it looks like that part of the lung metastasis is not vital anymore. And this was a patient, this is the heart, with metastasis around the heart. And you can easily see it. And so we concluded after those 25 patients, we treated for imaging, for diagnostics, that we found in adenoid cystic carcinoma patients that 93% of the patients could be included in a study with treatment with PSMA, and only 40% of the SGC patients. And that is because you need, we call it the tumor-liver ratio. It's a little bit difficult to explain, but you need really to have high levels of PSMA, very high levels, otherwise it can't work. And so we started the LUPSA trial, and we started it with the aim to evaluate safety and efficacy of 177 lutetium PSMA in salivary gland cancer. And the study population were patients with recurrent and or metastatic adenoid cystic carcinoma or salivary duct cancer. And the inclusion criteria was that those patients need to have a positive gallium PSMA CT scan, especially in one or more lesions, and they need to be more than 1.5 centimeters, because otherwise you can't see them with PSMA, with PET, above liver level. And the study design, it was a phase 2 pilot study, single center, 2 cohorts, and those patients were treated with 2 to 4 cycles of 7.4 GBQ 6 weekly. And after 2 cycles, we made a CT scan to see if there was not progressive disease, that the tumor was not growing. And if that was not the case, patients received another 2 cycles. And at this moment, the study is closed. We will close it next week. We included 10 ACC patients, 5 due to the ACC Research Foundation. Thanks for that, Jeff, again. And we try to include also 5 SGC patients, and that cohort will also be closed because I will present those data at the ESCO, and it's not so interesting for you to hear that story, but I will inform you on the adenoid cystic carcinoma patients. So what did we do? I'm sorry. This was the treatment schedule. So every block is 1 week. Every 6 weeks, we injected lutetium PSMA treatment. Then the patient was an outpatient clinic visit. in which we also took circulating tumor DNA, and that will be also analyzed. And we did, after 2 cycles, treatment evaluation, and of course, thereafter. And after treatment, they got 3 monthly follow-up. We screened 14 patients and 10 started treatment. And reasons for ineligibility were in 2 patients a negative PSMA PET, and in 2 brain metastasis and epidural metastasis. And the follow-up now, or this was in October, is almost 12 months. The range between 6 and 2 years, 6 months and 2 years. And the median number of cycles was 4. And of those 10 patients, half were male, 5 females. The age median was 62 years. 1 had only local regional disease. 2 patients had local regional and distant metastasis, and most patients had only distant metastasis. And the sites of the distant metastasis were lung, pleural, liver, bone, distant lymph nodes, or other. And 2 of them had prior systemic treatment. Well, this is a pre-treatment PSMA scan, and we saw very different pictures. This was a patient with lung metastasis, and she was included. This was a patient also with lung, but with a higher expression, as you can see, and this patient had a local recurrence. And it was safe to do it. That's not a problem. The most common observed adverse events were, and we call that grade 1 and 2, but it is very limited. It is, you have a little bit nausea only for 1 or 2 days, but you can eat and you can drink your food, but you have a little bit discomfort in your stomach. A dry mouth we saw very frequently. We know that's that side effect because that's also one of the side effects of PSMA treatment in prostate cancer. A part of the patients got some anemia, but not very severe, and some fatigue for 1 week in most patients. And grade 3, that's more impressive toxicity, that is that the patient, well, that it's more severe. That was only in 2 patients with low lymphocytes and a low sodium. But we didn't observe very severe toxicity side effects. But then the efficacy was very disappointing at this moment. So we didn't see any response, not a complete, but also not a partial response. And we saw in 6 patients stable disease, and in 4 progressive disease as first evaluation. But it is good, and I will not show it now, but and we need to calculate it better. But in part of the patients, we saw that there was a certain increase of the metastasis before going in the study, and then the increase of the growth, so the rate of growth was flattened, if you understand what I mean. So the tumor, it seems that the metastasis stopped growing during treatment, but we need to look at it better, and we will do that. Well, the progression-free survival and overall survival, I'm not sure if this kind of pictures, that you know those kind of pictures, and it is not telling you a lot of things because, well, it is only this treatment. And so part of the patients, they are still living in a relatively good health and a good quality of life. But part of the patients are died in the meantime. So in conclusion, the lutetium PSMA in salivary gland cancer is well tolerated, but the efficacy is limited to stable disease at this moment. But what we are planning to do, and that's very important, and a new PhD student in my department in my group, research group, will start the 1st of March, so almost the end of this month. And we are going to perform dosimetry, and that is that we investigate. We made SPECT CT scans after each injection, the first 2 especially, and then we can calculate the amount of radioligand, so which was in the metastasis or the local recurrence and in the other organs, to think on how can we go on, and is it important to have another schedule in salivary gland cancer in adenoid cystic carcinoma patients? Maybe we need to do other things with PSMA to be effective. So this study is not ended. We are fully in evaluation and analysis. And after the dosimetry, we have the answer how to go on. And these are acknowledgements. We do a lot of research in our department. So I'm very glad with our Dutch Patients Society Salivary Gland Cancer. And we work closely together. Thanks to Jeff for supporting our study. Maaike Eijer was the PhD student for the PSMA study, but I work also together with the Department of Urology. And for this study, James and Martin from the Department of Radiology and Nuclear Medicine helped me enormously. So thank you for the opportunity and the invitation to share with you our studies.